The case presentation from Government Hospital. Case is being presented by Dr. Harika Sajja, and the moderator is Dr. Prasanth from General Hospital. I invite Dr. Prasanth and take over the moderation. Dr. Prasanth, please be on the dais.
Providing this opportunity to present the case. At the onset, this case was actually worked up, and this case, especially it is actually a spotter. It is not a case we are presenting as a very short topic, very short, and actually this is a spotter. And this peculiar general examination finding was noted by Dr. Jayan. Dr. Jayan is our senior physician. Actually, this was worked out by him and evaluated by him also. We planned to present this case during the last APA meeting. At that time, Dr. Sajja was on leave. And this time, we planned it for this time. At this time, Dr. Jayan was on leave. And so he entrusted me to moderate the session. And with the due acknowledgement to his work and efforts, I am inviting Dr. Sajja to present the case. Actually, Dr. Sajja is a MD second year fellow at Amrita Medical Institute. She is not at GH Ernakulam. She visited GH Ernakulam as part of their DPR program, DRP program, District Rural Program. She was there for 3 months. At that time, she noticed the case and worked up the case.
This is a 61-year-old female from Thrissur with comorbidities of systemic hypertension, type 2 diabetes mellitus, and chronic kidney disease. She actually presented with complaints of abdominal pain since 2 days, nausea and vomiting since 2 days. With personal history, I'm not going in detail with the complaints because it's not relevant to the case. Personal history, her appetite is normal, bowel and bladder movements are regular, sleep is adequate and no addictions. Family history, diabetes mellitus in mother, no sudden deaths in family, no genetic diseases in family. Menstrual and obstetric history, menarche attained 12 years back, 1 normal delivery, healthy child, no previous abortions. General examination, she is short stature, moderately built and moderately nourished, with pallor being present and limb deformities, multiple are noted, which I'll come to the picture later. Systemic examination, no specific findings. I want to mention predominantly as higher mental functions as normal. Other systemic examinations are normal. So coming to the limb deformities which we observe, in her left hand, short third and fourth metacarpals, positive ulnar variance. And in her right hand, short third metacarpal, positive ulnar variance. And in her lower limbs, query left side short tibia and left varus noted. And in her foot, short first metatarsal of left foot and hyperextended second and third metatarsophalangeal joint with flexion of interphalangeal joints of third. So the past history is smallpox at the age of 1st year.
Actually, that was the general examination finding. This patient actually admitted with DKA, diabetes ketoacidosis. But during the rounds, Dr. Jayan noticed these asymmetrical limb abnormalities in a 64-year-old lady. This is actually a spotter. Any comments from the audience? This is a clue. 64-year-old, born at around 1960s. Got smallpox at the age of 1. Her head was normal size head. And her limb abnormalities was noticed during the growing age. It was not present at the infancy or in the childhood. It was noticed during the after 10 years old. And the abnormalities were asymmetrical. And we will proceed to the X-rays.
The X-ray of left hand is left third and fourth short and metacarpals and articular surface irregularities. And right hand is third short metacarpal, irregular articular surfaces. And wrist is showing right and left dislocation of ulna in both hands and irregular articular surfaces. And the main being left elbow, olecranon process and radial head bony expansion, query dystrophic calcification, diffuse osteopenia, joint space is preserved, epiphyseal destruction, and periosteal reaction is noted around the elbow. And right is also the similar findings in elbow. And knees, suspicious shortening of left femur, bilateral lateral condyle bony expansion. An ankle in right and left, articular surface bony expansion, joint space is preserved, joint alignment is maintained. Left foot, articular surface irregularities, articular surface bony expansion is noted. So, any differentials?
We consider the differential diagnosis of.
Yes. The first is Albright syndrome, that is 2q37 deletion syndrome. It can be ruled out because these patients, even though patients are having short stature and brachydactyly, which is observed in X-rays of forearm, so these patients will also have mental retardation, developmental delay. So that can be ruled out. And epiphyseal dysplasia, that can be also ruled out because these patients will have at age of 5-6 years they'll have joint pains, and this history will also be present in the families. Turner syndrome, they'll have delayed menarche, and they'll have the puberty delay, and they'll also have web neck and all gonadal dysgenesis. So that is also not seen in this patient. That is also ruled out. Second is pseudo hyperparathyroidism. So this is like a parathormone resistance. This is also ruled out because her laboratory parameters showed no hypocalcemia and hyperphosphatemia. And trichorhinophalangeal syndrome. This is also ruled out because patient did not have any facial anomalies. Facial anomalies such as protruding ears and sparse hair, lateral sparse hair, and flat philtrum. Last, other two diagnoses are achondroplasia. In that, upper proximal limbs and proximal thighs are involved. Even if metacarpals or metatarsals are involved, they're usually symmetrical. So that both the achondroplasia is also ruled out. Based on the X-rays, other possible diagnosis is acrodystosis. That is ruled out because usually these patients die within the age of 6. So this brachydactyly can also be seen in multiple genetic conditions, but these patients do not survive this age group, so hence they were all ruled out. So last being osteomyelitis variosa. So that is a smallpox complication.
It's a complication of the smallpox. She had smallpox at the age of 1 year, and it has been noted in the literature also. Very few cases have been there in the literature. One has been reported from the Medical College Trichy, and she will talk about osteomyelitis variosa. What is the characteristic difference between osteomyelitis variosa and achondroplasia? Achondroplasia usually involve the upper part of the limbs, the upper arms and the thighs. They will be shortened, and in this there is a lot of joint involvement is there. Just like arthritis-like picture, and there will be a lot of periosteal reactions and joint widening, dislocations, and the shortening of the metacarpal will be asymmetrical. It will not be involve all the metacarpals or the metatarsus. It will be selectively, especially the most characteristic is the third metacarpal. Okay, carry on.
Yes. So in India, it is eradicated. Smallpox was eradicated in 1979. Since she was born before that, so she was affected with smallpox. So this is the X-ray of pseudo hyperparathyroidism patient. The similar X-rays can be seen, like brachydactyly of first and fourth and fifth fingers can be seen. And this is also an X-ray of rhinopharyngeal syndrome, that also brachydactyly of fourth and fifth can be seen. So coming to osteomyelitis variosa, It is an accepted terminology for skeletal involvement which appears during the recovery period from the smallpox eruption. And the term osteomyelitis variolosa refers to osteolar articular infection of variola major only seen in cases arising in childhood during growing age especially, and tends to affect predominantly the elbow joints among the other joints. So it is caused by variola major and variola minor, genus orthopox virus, family Poxviridae, and subfamily Cordopox virinae. So only 0.2 to 0.5% of patients or 2 to 5% affected individuals only had skeletal manifestations. This is usually seen in secondary viremia stage of smallpox. And osteoarticular complications of variola infection usually manifest after 1st to 4 weeks, initially starting as elbow joint swelling, followed by long bone involvement. 80% of these cases are involved in elbow, followed by other joints. Ribs, spine, and pelvis are relatively spared in these conditions. And characteristic radiographic features of disease during evolving phase are physeal separation, epiphyseal site with epiphyseal destruction, and extensive periosteal reaction, often extending along the whole length of shaft of the bone. Elbow is the most frequent joint. So the most common features are seen in central cavitation of distal humerus with enlarged and deformed condyles, thickening and enlargement of olecranon and radial head with eventual subluxation, dislocation or ankylosis of joints, and absorption of central trochlea with elongation of both condyles around the elbows, and sclerosis around the elbow with enlargement of olecranon process of ulna and radial head. So after eradication, only 9 cases were reported in India with osteomyelitis variolosa. So out of 9 cases, 6 are symptomatic. So they came with arthritis features and 2 came with pathological fractures, and among the 9 cases 2 are asymptomatic. So this patient was also asymptomatic. She did not have any arthritic features, but in most of her x-rays dislocations and subluxations were also noted. So this is one of the osteomyelitis variolosa, one of the case report which is published by Dr. Jain in his PG time. And this is one of the case report which is published by Dr. Joe Thomas of Astor. Thank you.
This was presented because this is very rare, and this is going to be even rarer now onwards. Because smallpox has been eradicated. Okay, thank you for your time.